Hello there, Dr. Suleiman here, Chronic Pain GP, and welcome to this short video. Today talking and discussing about history taking for the clinician and how chronic pain patients present. So the first question I often ask patients when they enter the consultation room is, tell me about yourself. Now this can sometimes be a bit of a surprise for the patient, but what I intend to do with this question is try and look at the patient as a whole really and how the pain has impacted on them. Once they've told me a little bit about themselves, I can then essentially open the questioning with using very open questions prior to using closed questions. So the first question I often ask is, tell me more about your pain. Often patients can go into some detail about their pain, and the best thing I can do at this point is just listen to them. I then can start with a series of closed questions, including questions such as, tell me more about when it started. Was there any obvious cause for it? Can you think of any periods of stress during your time when the pain first started? I can then move on to more specific questions about the localization and where the pain is felt initially. Does it radiate anywhere, for example? I then ask the patients to specifically describe the pain, and this is where the use of language comes in with pain patients. They often use metaphors, similes, metonyms, and they use expressions such as dull, sharp, explosive, toothache-like, I feel like a bomb's exploded in my head, doctor. So people have different ways of expressing themselves, and sometimes there are cultural differences as well. Then move on to see if there are any associated symptoms with the pain, such as stiffness, particularly in the mornings, or swellings of joints, which can give certain direction to me about which way I can then progress the questioning. I also ask about pain-free periods and whether patients are in constant pain or whether they have fluctuations in pain or whether having certain pain-free periods correspond to specific life events, for example, going on holiday or not being at work. Questions which get to the heart of the pain can often take a long time and can be quite draining for the clinician. However, I feel patients who live with the pain 24/7, 365 days per year are the experts in their pain. And the best thing we can do as clinicians is to sit back, listen, and digest the information they have provided for us. As there's no objective way of measuring pain as yet, I then ask about what their pain feels like on a pain visual analog scale, where 0 is no pain, and either 10 or 100 is the worst pain ever felt. And ask them to average this out about how they feel their pain is on an average day. Specifically, if patients have presented with chronic low back pain or acute low back pain, I can then ask them about the red flag symptoms. A helpful acronym for history taken in pain is one called Socrates. So here we are. It's asking about the site, the onset of the pain, the character of the pain, where and if it radiates, any associated symptoms, how long it's been there, any exacerbating or relieving factors, and the severity of the pain. As often I've seen patients who've had pain for many, many years, I can then ask about investigations, whether that's blood tests, ultrasounds, x-rays, MRI scans or CT scans, and what the results were. Now the next question I feel is probably the most important question in taking a chronic pain history, and that is, how does the pain impact on you on a day-to-day basis? For example, does it stop you playing with the grandchildren? Does it stop you going to work? Has it stopped you doing those things which you find important and enjoyable in life? From asking this question, you can then assess the level of fear avoidance perhaps, or catastrophization in patients. Conclude the history taking by trying to have an element of optimism, and I often ask the patients what they would like to achieve moving forward, whether in the short term, medium term or long term. And another question which sometimes stumbles the patients is, how do you think I can help? Often the answer I get back is, well, you tell me, you're the doctor. However, I feel that this question can help with collaboration, an element of education and forward planning with the patient at the centre. Now the language that patients use to describe their pain can be very interesting and give me a general idea of how the pain is impacting on them day to day. And they often use specific descriptive and figurative language. Figurative language such as metaphors, pain is a killer or pain is a monster. Similes, it feels like putting my hand in a beehive, doctor, and that's specifically often describing neuropathic pain. Metonyms, the stinging, burning is there all the time. They can use hyperbole. It feels like a bomb is going off in my head or my head is exploding. And personification. It feels like someone has their claws in me. Sometimes the language used is very descriptive and emotive and can become quite upsetting, not only for the patients but the clinician themselves. I feel sometimes where patients are using very descriptive, emotive language, it is their way of expressing to the clinician that they want to be taken seriously and they want the clinician to believe that they actually are in pain. It does tend to happen more if the patient's first language is not English. It sometimes occur if the patient is seeking specific investigations or treatment. The history-taking component of chronic pain is extremely important, and I still believe that a diagnosis can often be made in 80 to 90% of the time with history and examinations. So that concludes today's video, and my video next week is intending to be on investigations in the chronic pain patient. So before I leave, I just want to remind you, you can subscribe to the videos and please feel free to leave feedback down below. Thank you for your time today.